Welcome to the Kol Shalom Lab educational series.
Hi everyone, my name is Mike Romano and welcome to our Neuroimaging series. This is part one of the series where we will cover the basics of brain MRI sequences.
So I'm going to take you through a sample case, how I would look at it as a radiologist. This is someone who's just kind of coming in with specific symptoms, maybe a concern for cancer. And yeah, I'll just kind of take you through and show you how we troubleshoot and use each sequence to kind of figure out a diagnosis. So the first thing I want to go over, though, is just a couple of acquisition parameters, acquisition types that are probably relevant for you as someone doing research. So the first thing is really how these images are encoded, broad strokes. So these are collected in an area or something called K-space, kind of a frequency domain if you're familiar with Fourier transforms and that type of thing. The K-space is transformed back into space, which is kind of what we're looking at, anatomical space for radiologists to see. So this is already a processed image. And there are two ways that you can kind of encode each of these voxels or volumetric pixels. So there's 2D and 3D acquisition methods. In a three-dimensional acquisition method, you encode the location of a voxel basically with in all three dimensions at the same time. In a 2D acquisition, you basically collect just one slice at a time, going down the body, either in the sagittal plane, coronal plane, or axial plane. And basically what happens, what this means is that a three-dimensional image, you have better reformats, and you have more true like volumetric pixels. So for example, if we kind of reorient this, the three-dimensional image, this looks pretty good. Whereas here is a T2, an axial T2 flare, just another example. So this is collected in the axial plane, and then we reformat it, and now it kind of looks like, trash. Not the brain, just the image. Kind of looks like trash. So if you're going to do a 3D convolutional neural network, it would make more sense to me to use any type of 3D algorithm. I would really look for the 3D sequences. And the downside is that they take a little bit longer to acquire, typically. But anyway, and I do want to kind of drop this as a recommendation. So this website, MAOS, they have really good, so we use eAnatomy. It's an anatomical atlas. I think it's absolutely fantastic. You should use it. eMRI looks pretty good. This is an example from it. They have descriptions about the different sequences, kind of complicated, but at a level where you'd be able to sort of understand. Okay, so without further ado, let's kind of get into these sequences. So the first thing, a T1 weighted sequence, this is a gradient recalled echo. There are a bunch of different ways to acquire these. These are structural images. We're just looking at brain structure. This is good you can really look at the different gyri, sulci, size of the ventricles, brain morphology overall. You can see atrophy of different parts of the brain. You can take a look at the gray-white interface right here. And yeah, you can look at soft tissues here. You can look at bones. MRI is not great for bones. It's not great, necessarily for vessels, other things. But this is a really good anatomy sequence. So, I guess you could kind of look at the temporal lobe, see if there's a lot of atrophy. Particularly these coronal images, I think are really nice. Look at the temporal lobes. You just see them right here. For mesial temporal lobe sclerosis, you could see focal cortical dysplasias, maybe you would see in epilepsy sometimes. Ectopic gray matter. those types of things. So this is really a structural thing. I think probably the most useful for finding, or do they have asymmetric frontal lobe atrophy or encephalomalacia or atrophy of specific areas. So um, and then to go along with these, this is not the order that I would look at this, during the day, but um, we have post-contrast images. So the post-contrast images, you're just looking for things that take up a lot of contrast, maybe hypervascular things like in this patient, a tumor. This is bright now. You might remember from a minute ago, this is not so bright. That is because it's taking up contrast. You could also see contrast around the edges of the brain on this sequence. Maybe if there's like leptomeningeal spread of tumor, maybe meningitis, things like that. You can see tumors along the dura, or tumors on the face or like the skull. Any type of tumor inflammation, you'll see increase in enhancement, like acute MS flares, for example, multiple sclerosis flares. Okay. So the next thing we'll talk about, just to kind of make it flow a little nicely, is the T2 sequence. So T2 sequence, this gray-white is reversed. There are only really a couple things that I think I know of to use this T2 sequence for. You could see this fluid signal, which is kind of nice. If there's like a cyst or something, you can sort of troubleshoot that with the T2. You also look at the vessels. This is kind of like the best way to look at vessels on MRI if you don't have an MRA or a CT angiogram. But basically, vessels should always be dark. Sometimes you could find aneurysms on T2 weighted sequences. You could find thrombus. If there's no blood flowing, the vessels won't be dark. So for example, here is an internal carotid artery turning into a left MCA. And you can follow these back a pretty good amount. The other thing is that, the dural venous sinuses, when, COVID, people are getting these like venous sinus thrombuses, dural venous sinus thrombus. So this should also be dark up here. And the other thing they're good for is looking at the posterior fossa where the cerebellum is. So sometimes on FLAIR, which is kind of the workhorse T2 sequence, we can't see this area quite as well. There's a lot of artifact because, there's like, air right here and, fluid, a lot of fluid around this area. So for the spinal cord and posterior fossa, sometimes the T2 sequence is better to look at this. And we'll talk a little bit more. There's some bright stuff here. This is actually tumor, but I'll talk about this a little bit more on the FLAIR next. So here's a FLAIR. So in the FLAIR, usually we like to look at like, white matter. You can see edema in the brain. It's going to be bright in the brain on this sequence. You can see gliosis, you can see tumor. These things, so this is an area of what we call T2 FLAIR hyperintensity. So you can see these in a couple of scenarios: migraines, chronic headache. You can see them with chronic small vessel disease. And sometimes like old strokes, but those typically further out. You'd see some sort of gliosis and regional atrophy. There's like a stroke. But FLAIR is also good to look at hyperintensities around the ventricles. So for example, if we look right here, we don't see any in this patient. They don't have multiple sclerosis, but you can see fingerprints, little humps kind of around the ventricles in people with MS, usually more dominant appearance of white matter hyperintensity from this fellow. Here you can see some of these like frontal FLAIR hyperintensity. So these, it's common to see, especially frontal hyperintensities in patients with migraines or chronic headache. It's pretty much always abnormal to see anterior temporal lobe FLAIR hyperintensities. So kind of, be on the lookout for that. I'm trying to think what else. That's pretty much it. So age-related disease, age-related like small vessel disease. Um, there's, I think, some purported correlations between flare hyperintensities and or microvascular disease and Alzheimer's risk, probably vascular dementia, definitely vascular dementia. I think there are actually like criteria that you can use, and like burden of white matter disease, and I may be confabulating, but I think there are. Okay, great. So the next type of image we're going to look at is called a susceptibility weighted image. This is pretty cool. So here you can kind of just look and see if there's any. Basically, there are certain types of metal that create what's called like susceptibility artifacts. Like so, and this sequence basically highlights those areas. They'll appear dark on susceptibility weighted imaging. Here is a small area. You scroll through it. It kind of pops in, pops out. This is a susceptibility artifact. It could be related to maybe a microhemorrhage, pretty common. Sometimes calcifications, and you can scroll through. Okay, that's really what we're looking at in this sequence. Sometimes you can also see, areas of microhemorrhage at the gray-white interface in patients with like traumatic brain injuries, axonal injuries, that type of thing. You can also see a lot of these areas in people with, cerebral amyloid angiopathy. I think there are a few studies showing that, you can predict different types of dementia, maybe with these like burden of susceptibility artifacts. Could be related to old injuries too sometimes. You just have a little microhemorrhage. You troubleshoot the sequence with, this is a phase. So you have like a magnitude and a phase. And if you are wondering what like constitutes these little areas, you can kind of see like what phase this is. This is a bright phase, whatever that is, corresponds maybe to other vessels. You could convince yourself this is probably blood. It's probably not calcium. The skull looks different phase here. So that's the troubleshooting. And then the last image we're going to look at is called the diffusion. I think this is really cool. I love this sequence. But okay, this is the B1000 trace. Okay, so there are a bunch of different ways to process these. These are very cool sequences. All these sequences have to do with how water is moving. There are different ways to look at it. These kind of standard sequences are, this basically just looks, I think if you look at like, well, anyway, reduced diffusion can be seen in a couple of conditions. So one of them is like very cellular tumors, like lymphomas. In this person's case, this is very bright here, which kind of makes sense. There's a caveat that I'll talk about in a little bit, but another situation would be in infarcts or strokes, acute. So basically, you'll see cellular swelling because the mitochondria stop working, which means the sodium potassium pump stops working. They swell. There's restricted water or reduced movement of water molecules around cells at that point. So it'll look bright on this sequence. The caveat to both of these things is that things that are T2 bright will also look bright here. So to disambiguate that, we will look at this is called ADC. And this will actually tell you, so, maybe there's some dark stuff in here. Maybe some of that is true reduced diffusion, but the other stuff that's still bright on the ADC that was bright in the diffusion is called T2 shine through. And that just means, we can go back to the T2 here, that, this is just bright because it's T2 bright. So diffusion is very useful, though. There are a few other sequences that are kind of like, that also look at diffusion through axons, like diffusion tensor imaging. Clinically, it's not really, to my knowledge, used outside of like surgical planning. But you can actually use tensors to map each of these axons based on like, how water molecules are moving through those white matter tracts. So we're trying to use it in the spinal cord. Again, that's kind of experimental. But, and then I'm trying to think what else. I think this is it for this edition, but let me know if you have any other questions.